Hello everyone, my name is Munawar Mecci. I'm a spinal injuries consultant in the Northeast Regional Spinal Injuries Center in Middlesbrough at James Cook University Hospital. Today I'm going to talk a bit about the importance of sharing good practice following good run of the clinics that we have established in the last few years. First of all, let me put this slide up to show you what this is all about. In fact, in a MASCIC meeting in Loughborough in 2015, I happened to meet Annie Glover, who was the lead for Cortis syndrome charity in UK. There, she had a few leaflets, and when I was asking her what this was all about, she showed me this program that they had following spinal cord injury. The clinical reference group was responsible for providing expert clinical advice on the treatment of injuries relating to the spinal cord. This, in fact, would also include the Cortis syndrome. It was recommended at the time that the patients with Cortis syndrome should be treated by specialist healthcare staff in spinal cord injury centers. We were not aware, at least I was not aware of this important group that we had to take care of. If you go back to the slide again, in fact in 2012, it was agreed that the local NHS organizations will be made aware of the decision so that they can organize their services appropriately. After meeting with Annie Glover, I thought I should have a look at our services in the first place. I found that this was in fact what I described as a lost tribe. They were incontinent of bladder and bowel. They were imbibed with shame, not having the courage to venture out. They were in fact self-isolating. There was no socializing, no more hen parties, no more stag parties, no more going to the pub, no holidays, no race course. Everything was lost. In fact, the relationships were breaking down, the marriages were breaking down, jobs were lost. In a way, I must describe this as these people marooned with no light in sight. Then we said, why don't we look at something to pave a way for a meaningful start? So what did we do? I said, okay, we know that there are very few centers where it is one service under one roof providing holistic care for this group of patients. How are we doing? So we wanted to put our own house in order, and I wanted to investigate. One of my colleagues, Mr. Farooq Aziz, who's a neurosurgeon, helped me collect data from the theater records for a period of 10 years, from 2006 to 2016. And we found that 85 persons who were given a diagnosis of Cortis syndrome were operated. And when I looked at my own number, there were only 7 patients under my care. Now this was quite worrying. Then I said, what do I do about it? And the best way was to network, to talk to people, spread the word around. So I started looking at the meetings that were available. We have a spinal consultant away day meeting 3 times a year. I'm invited also to those meetings. This is where I brought it up. This is where I put up what I had learned from MASCIC, and they said it was a surprise to them. And I presented once, I presented twice, I presented thrice. I was at it. I wanted them to realize how important it is to upgrade this service. Then I presented it in the Northern Trauma regional trauma network meetings, and we had a full day of speaking about it in a regional nursing and social care spinal awareness day. Yeah. And then I presented it, our initial report after a year. I presented in MassKip. I returned to MassKip. They gave me 10 minutes. I thought that's good enough. I wanted to make myself heard. And then in a national meeting in, I think it was Oswestry, I was unable to go there because I was not well, but it was presented by my colleague saying that our pathway, and we showed them what we were doing. Our solution and how it works. We thought of a care pathway which identifies patients who develop Cortis syndrome and making sure there is early referral to the regional spinal injury center to make sure the patients are no longer incontinent, make sure the mobility is improved. Implementation. As we know already that the centers are commissioned to provide Cortis care, but nowhere was such a holistic care clearly identified being provided under one roof. So I had this charge. We are unique because I have got all facilities under in my services, and I can get in touch with anybody I want across the corridor. I can get them to see my patients, asking them to come and see them the same day. So a pathway was created. A rapid access clinic for community patients was established, and the first clinic commenced in February 2016. Initially it was ad hoc, and later we now established clinics on a regular basis. Then we were talking about this pathway. It's a bit, you can see from here that I employed this in our own trust. The referral, electronic or paper form within 24 hours to spinal injury centers. If operated early in the weekend in my center, there should be a referral on Monday morning. Patients will be seen by the spinal injuries consultant, that is me, on the same day. And later we found that Dr. Ong was also involved, and either him or I go and see the patients in the ward. If neurological examination confirms that this is Cortis syndrome, patient is transferred to the spinal injuries ward for rehabilitation. Patients will receive 4 weeks of intense training in bladder and bowel management, and training with upright mobility with ankle foot arthrosis if necessary. They will be met by the named consultants from various specialties, i.e. urology, pain consultant, psychology, sexuality counseling, and who will introduce themselves for future follow-up care. Each one of them will come and shake hands with them to show their face to say, this is who we are. If you need us in the future, we'll be there to help you. After discharge from rehabilitation, these patients will be seen for follow-up by us in the spinal injury center at 3 months, 6 months, 12 months from the time of surgery, and annually thereafter. At 3-month follow-up, they will have an ultrasound scan of the kidneys and bladder, and annually thereafter, a video urodynamics between 3 and 6 months by my colleague Mr. Fulford, consultant urologist, with an interest in neurourology. We have referral pathways to the pain clinic, sexuality, fertility clinics, psychology, colorectal surgery for colostomy if required, and during follow-up. And we had put in some outcome measures which you can see, which we utilized for up to 2 years. What I found was it took a long time. It took about 45 minutes to fill those forms. So we changed that. We opted out of it after discussion with my specialist nurse in the clinic, and we simply use KIM, spinal cord injury measure, to look at the score, which is much more easier to use, and all of us know about it. Then there's these questions: spinal cord injury versus Cortis syndrome. Are they different? What I have put forth is the rules of engagement do not change. What we apply for spinal cord injury applies to Cortis syndrome. There is no such thing as a brief admission. As long as it takes, that's what I insist on. We should have proper goal plannings, look at their progression, look at their independence, look at their home circumstances. Are they able to go home independent and look after themselves? Are they able to return to work? This is what we address. And we follow up the set times annually for life. And the door is open 24/7. They can pick the phone, ring their named specialist nurse, who will get in touch with me, and we see them as a drop-in at the earliest opportunity. Let me tell you a story. This is a 28-year-old female who resided locally, went to Egypt as a horse trainer. Unfortunately, she fell from the horse and broke her back. She became paralyzed. She had a dense Cortis syndrome. And she was admitted to a local hospital in Egypt, in Cairo. It was not a specialist center. She was on this ordinary mattress. She had a tube in the bladder. There was no bowel management. There was no manual evacuation. She was constipated. She was fecally incontinent. She was in tears, asking for help, crying for help. There was a problem with the language. There was a barrier. Nobody knew English properly enough. Then we came to know that she was there. We have to take her. By the time she got to us, it took 6 weeks. And then we had to communicate with them. I could not, because they wouldn't understand what I'm saying. Neither would I. The Arabic language I could hardly understand. So we got in touch with one of our colleagues here who speaks good Arabic. He was the translator between them and us. Ultimately, she came to us, you can imagine, in bad shape, constipated, incontinent pads, pressure ulceration of the sacrum, very tearful, afraid. On top of this, she had picked a rare bug in Egypt while she was in that hospital, and our ID consultant suggested to us that she should be nursed in a separate room for the whole time of the rehabilitation. And this is what we did. She was in a side room with access only to the courtyard. She was not the mainstream patient to access therapy sessions in the department. The therapist went instead down to her room to do therapy sessions in her own room, and that's how it lasted. And ultimately, we completed her rehabilitation. It took longer than usual. And if somebody says it is a brief admission, this is what I'm trying to point out. She took more than usual, several weeks, months before she was independent to be leaving here. And then I saw her in the outpatient clinic as suggested, and on the second year of follow-up, she asked me, can I go back riding? I want to ride my horse again. I said, yes, I will consult with my spinal colleagues. I put this most recent x-rays in the spinal radiology meeting, and I said, this one of my patients, this some of them knew very well, would like to take up horse riding again. What do you say? They said, yes, why not? There she is, riding again, happy chappy, living on her own in this part of the world. Okay. And this is what we should be doing. We should be sharing. We talk to my own staff. We talk to them about it in the multidisciplinary meeting and the regional trauma network. I bring this up always, and they say, here he goes again. I don't mind that. I keep bringing it up again and again. All specialties that can provide with necessary care and intervention, I always pick the phone and say, hey, one of your patients is here, why don't you come along? And I have got that, what you call the advantage over any other center in the United Kingdom. What are the challenges? Is the awareness there? I don't think there is. We should further regular education to healthcare professionals to ensure early referral and recognition that expert intervention can be taught. After following expert intervention, patients can be taught to manage their condition and have a life. What are the implications? This is ensuring there are prompt referral. This is the biggest barrier. I see patients coming to the outpatient clinic. We are told after the patient has been discharged home from other centers. The pathways presented with spinal and trauma networks meetings. I'm going to continue to do that. Lengthy outpatient consultation could not be accommodated in the existing clinics, spinal cord injury follow-up clinics. So we established dedicated clinics for spinal cord equina syndrome within the existing resources. We did an audit, and we found that the results were looking positive. And this is one of the patients who wrote to me. He was out in the community having discharged from a hospital somewhere in the north, and he had been struggling, incontinent, not leaving home, depressed, lost his partner, lost his work. After having provided service here, this is what he had to say. He said, I secluded myself. Incontinent was always on my mind. Relationships were non-existent. And I thought this would be my life forever. My life has completely changed. I have a life. I cannot say how glad I am that I was referred here. Now, after careful consideration, I created a pro forma for use in my center. I think I will go through this very briefly. Patient's name, age, GP, etc., receiving consultant, presenting symptoms and signs as leg pain, loss of urinary sensation, urinary incontinence, painful retention, perineal numbness, fecal incontinence, loss of pinprick sensation, absent bulbocavernous reflex, absent anal contraction, and foot drop. Is it unilateral or bilateral? Then 3 main headings were also included: level of herniated disc, time from onset of symptoms to referral, time from onset of symptoms to surgery, time from referral to surgery. If we could capture all those events in one sheet of paper on an A4 sheet at the time of admission, that will give us a very good research tool, if you like, or even an audit tool to look at it and to say, where is the delay? How could we address this? Like my surgical colleague mentioned, that the delay has been mostly in the primary care facility. So what we are thinking, what I and he discussed, was that we will have probably to invite our primary care physicians to meetings to make them understand, make them aware of the cord equina syndrome and how delays in referral could be avoided. So what we have found is, it is not so much early intervention or the intervention timings. What we have learned is, although it is an important part of intervening earlier, sooner, what is also more important is trying to create awareness in the primary care setting to recognize these events and not send them home with a pain medication to be seen tomorrow or the day after. So I think we will try to do that. We'll arrange meetings in the future and continue to network with people and create more awareness among the professionals. Having said that, my thanks are to Claire Thornburg, who has always been instrumental in moving this forward, and also to my friend here who's an IT consultant, Darren Watson, who is really amazingly good in all my work that I do in presentations and other work. I must also mention Glynis Peet, who's our clinical director, who had kindly arranged honorary contract for Claire Thornburg to fill the gap for sexuality counseling. Thank you.